we have to realize, as human beings, individuals, we live not in silos, we live in a community, and we're exposed to various exposures, both environmentally and socially. So you can see that we're exposed to the climate, we're exposed to the air quality, food networks and food environment around us, light pollution, noise pollution, temperature, and also the social environment around us. So, like I explained about the cardiovascular risk factors and how people adapt to the environment around them. But also now we're overloaded with all this information, radiomics, kind of looking at imaging, looking at social networks, understanding genomics, understanding metabolomics. So that's really what intrigued me, and kind of understanding how can we take a step forward to understand cardiovascular health within the context of what I call the exposome, which is the exposure, the totality of the exposure. Interestingly so, most of the literature, before I started kind of looking into the literature, most of the literature has been derived from studies that looked into patients who are healthy, and they followed them up for incidence of myocardial infarction or cardiovascular death. So I was really interested in understanding how do our patients with pre-existing cardiovascular disease fare when they are exposed to air pollution. So one of the first studies that I did was looking at the UNOS study, UNOS registry, which is basically the solid organs in the United States. And after getting some permissions and so on and so forth, we linked all the patients who received heart transplantation with metrics or measures of air pollution that is ambient, annual. And we showed that there is a semi-linear relationship between particulate matter exposure, and you can see the levels here on the lower side compared with what I showed you in the previous slide, because that's in the United States only, and the hazard ratio. And if you see, for example, where there are areas people living in about 16 or so, for example, Cleveland, Ohio sits about 12. There are some areas in the country that have about 12 to 15. The hazard ratio as compared with areas that is very low, about 6 or 5, it's about 1.26. About 1.5, right? And for each 10 microgram increase, there's about 1.26 increase in hazard ratio. This is not minimal. This is something that is really dramatic when we talk about mortality in patients who have heart transplant. This is equivalent to some of the new immunosuppression, some of the newer techniques in heart transplant. So the differences are not minimal. The differences are huge. We talked mostly about adults, but thinking about the exposome, you're exposed to it in utero, and then you, as an embryo, fetus, infant, child, adult, and older adult, that can actually shape your health, and both from a cardiovascular risk factors on the y-axis and cardiovascular events, of course, which happens later in life. But you can think of all of these factors of the exposome: temperature, green space access, sleep, and air quality, and so on and so forth, which can shape your health. And if you have a healthy exposome versus an adverse exposome, that can actually help you live longer, but also live happier and with less risk. I've showed you, for the most part right now, individual components of the exposome, but I hopefully convinced you that the exposome components can actually be interactive and can be additive to each other. So we started to use some of the data science approaches, emerging machine learning approaches, to try to understand and rank and kind of look at the intersection between some of these factors. So this is one of the first examples or proof of concept where we look at the premature cardiovascular mortality in the United States, and it looks, there is similar to the previous maps that I showed you. There is significant variation, and we asked a simple question: what can explain this variation? And we basically have a myriad of exposure variables, including socioeconomic, but also environmental. And you can start to see things that are really interesting. This on the right side of the curve here, you can see this is the importance of these variables as they relate, the strength of the relationship when they're added all together. And of course, income and poverty come at first, but then you start to see things that are interesting from an environmental exposure. So food insecurity, even broadband access to the internet, SNAP benefits, and that part of this food security as well. You can start to see that there is air toxics show up here in the top 15 or so, access to exercise opportunities, and so on and so forth. So this kind of proof of concept pipeline helps you understand and rank and try to understand what is really important in these relationships. So in cardiovascular, it's no surprise that because cardiovascular disease is the #1 killer in the United States and globally, then we have a lot of devices, we have a lot of things that we do in cardiovascular disease. So the combination of these two can actually make cardiovascular field, both surgical and medical, to be a major polluter and major contributor to this. So transportation of patients and staff, pharmaceuticals, food even for patients and staff, energy use in the cath lab. You go to the cath lab, it's freezing cold, right, even at night. Medical devices, we throw a lot of stents that are 1 day old or 1 day past the expiry date. We throw a lot of ICDs and probes and so on and so forth. And of course, there's single-use disposable. So how can we solve this, and how can we move from where we are right now to sustainable cardiovascular care? Of course, it's complex, but starting with systems thinking, we have to change the culture. We have to educate our fellows and residents and medical students about sustainability and how can we care for the environment at the same time as caring for our patients. But also, I think, of course, I'm biased, but I think prevention of cardiovascular disease can lead to less stents, less bypass surgeries, and less masks used, right? So how can we think about prevention a priori? And it goes back to full circle here, right? So you care about the environment, which helps with reducing, improving prevention, and it goes back to reduce impact on the environment and so on and so forth. And of course, how can we, attack, so to speak, or intervene on poverty, nutrition, education? We need technology innovation. So how can we understand, for example, how can we reclean some of the single-use things that we do, and evidence-based clinical practice. So for example, one of the things that, waste in medical use, right, on testing and so on and so forth. We also need to understand how can we recycle some of this. There's actually a lot of evidence that ICDs and pacemakers can be reutilized after proper cleaning. Can be from, when a person dies, it can be explanted and reimplanted in another individual. So a lot of this is hopefully, the next generation can solve a lot of these problems.